All right. Good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today and pay my respects to their elders, past, present, and emerging. Firstly, a little housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions, you can submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of your screen. So today we're going to be hearing from Dr. Katrin Gerber and Dr. Lidia Engel. Katrin is a mental health and end-of-life research fellow at Nari and Mark with a PhD in psychology from the University of Melbourne. While Lidia is a postdoctoral research fellow at Deakin Health Economics. She is currently leading the economics of aging and dementia. And today they'll be presenting Grief Has No Expiry Date, mixing poetry and health economics methods to explore the bereavement needs of older people. So welcome, Katrin and Lidia, and over to you.
Thanks so much, Jess, and thanks for the invitation. Hello and welcome everyone to this presentation on grief in older people. Now, at some point in our lives, we will probably all have encountered grief, which is the natural response to a significant loss. And in this study, we focused on older people and grief that is caused by a bereavement, so the death of an important person in someone's life. And the first question that you might have is, why should we care about the bereavement experiences of older adults? Now, older people are more likely to encounter the death of a loved one than any other age group. And that alone should put them at the center of bereavement support services. For example, 71% of people over the age of 65 have experienced at least one bereavement in the last 2.5 years. So it's a really common experience. But in healthcare and in society, there is this notion that older people are well prepared to deal with grief simply because they have encountered so many bereavements throughout their life. And we wanted to see if this is true. Now, in this study, it's a project by the Melbourne Aging Research Collaboration, and we brought together 16 representatives from 10 partner organizations. And we wanted to find out, how does grief affect older people's health and well-being? Are older people seeking help through the healthcare system, and how does that look like? And what are potential barriers in the currently available bereavement support? We did a mixed method study. So we did a large nationwide survey of bereaved older people, and Lidia will talk about this a little bit later. But we also wanted to capture the personal stories of grief through in-depth interviews. So we interviewed 18 older adults between 66 and 87 years who had experienced a significant bereavement. And this was often the death of their partner and had occurred on average about 8 years ago. We also interviewed primary care staff, so GPs and nurses across Australia, to see how grief in older people looks like from their perspective. And we analyzed the interviews thematically, but we did something quite unique with the interviews. We turned some parts of the interviews into poems. Now, this is called poetic narrative analysis. It's a form of arts-based research where you create poetic statements by carefully crafting poems around certain topics. And you're arranging and rearranging participants' exact words. So nothing is being added or significantly altered. We then invited participants and volunteers to read their poems while being recorded. And I'll show you this in a moment to let older people share their experiences themselves. But before I do that, I want to make 2 comments here. The first one is that everyone has a slightly different idea of what constitutes poetry. And these poems are written in free prose, so it's nothing that rhymes. They're more like poetic statements. The second comment is a trigger warning. So these poems address death and dying, grief and bereavement, and they can be quite emotional and maybe upsetting to some people. So I'll now let some of our participants share their experiences with grief, starting with Ellie, a mother who had lost her adult daughter.
I couldn't leave her. I went on the day she died. She was dead in the bed. I asked her husband permission. Could I sit with her? I couldn't leave her. I had to sit there with her for hours before her body was collected. That was the hardest. I just couldn't leave her. I kissed her. She was cold. Then she was taken away in the back of the van and I collapsed. My sons held me. I just couldn't leave her.
A permanent condition. I'm still hanging on to the familiarity of her presence. I feel that if I go to the hospital where she died, I'll be in familiar territory with kind people. Each day is now empty. At the hospital, I was asked if I was married or single. I burst into tears. Being married for 47 years is a permanent condition, unchangeable, except until death do us part.
Keep going. You don't expect a child to die before you do. He was quite a private person. He kept any difficulties he had to himself. He had the most caring hands. He threw himself in front of a train. He would call me and see me in the mornings. I would often get an email saying, "Don't miss the beautiful morning, Mum. The sun's magnificent. The colours are spectacular. Make sure you don't miss it." The days seem much longer because I had him to look forward to. I miss all that. Life has changed. There are many people who've been through terrible things. They've kept going. I've got to keep going. I hope that I can help other people because that means that there's some purpose left in life, doesn't it?
Forget Kubler-Ross. I went through 3 stages of bereavement. Forget Kubler-Ross. The first was trauma, stunned mullet type of impact. Overcome with sobbing, nobody saw that. Uncontrollable. Cathartic, scary. The next stage, missing him. I missed the company, having him around. Him, the physical presence, someone to talk to and listen in bed at night. And then bereaving, the loss of the relationship, not being one of two, one half of a couple, talking about my house, denying that it had been his house, saying we all the time. Now I had to talk about me all the time.
So you can see here how incredibly moving these stories are. And I now want to talk to you a little bit more about the findings from the qualitative part of the study. One thing that really stood out in these interviews was the sheer amount of bereavements that all the people had encountered. Over their life, all had been exposed to multiple deaths of close family members and friends, and this accumulation of losses was a huge stressor. People talked about a ripple effect of grief, that the death included also the loss of their role, a sense of identity, family, and community. And this had long-lasting consequences for their health and relationships. And someone said their impacts beyond the death that resonate down the years. Now, participants discussed various physical and psychological effects of grief. And you can see here the different shapes of grief. And these ranged from very negative emotions like shock, tearfulness, longing, anger, apathy, or guilt, to also more positive emotions like acceptance, relief, gratitude, or resilience. And while most people focused on these mental health effects of grief, many also reported physical symptoms like memory loss, difficulty sleeping, changes in appetite, or pain that increased after the death. Grief and substance use was often mentioned, and in its most extreme form, grief was connected to increased mortality rates. Suicidality was discussed, and we know that especially older men are a high-risk group when it comes to suicide. And some participants also shared stories where family members had died within a short time of one another. So for example, one parent died on a Monday and then the other one just went downhill and died the following week. And this always sounds a little bit coincidental, but we know that the stress and the shock of grief can affect older people's cardiovascular system, cause the rapid onset of new conditions or the worsening of an existing one, which can then lead to an early death. And this is commonly known as the widowhood effect, or dying of a broken heart. So which strategies did older people use to deal with these tough experiences? Being able to prepare for the death helped with the grief. One participant, for example, remembered getting quite clear instructions from his wife before she died. He said, "She and I spoke about what it would be like for me on my own and how I should be cooking and living. And we even talked about the women in my life that I should seek assurance from." Sitting vigil with the person as they died and also handling the body was really important. And so were things like funerals or rituals, like visiting the graveside. Many people used daily reminders to keep their loved ones' memory and legacy alive, like photos around the house were a really great conversation starter when people came to visit. And this related to voicing loss, which is one of the most dominant themes. Many people needed to talk about what happened over and over, but they found that family and friends had very limited patience for this. So older people often ended up grieving on their own. So they tried to keep busy by finding new and meaningful activities, but that was especially hard during COVID. With the lockdown and the cancellation of many activities, people had a lot more time to think about their loss. And this was seen as very confronting. So dealing with grief was a lot of work, and sometimes people needed a bit of extra help. If they did seek help from the healthcare system, their GP was the first point of contact. GPs and nurses knew that older people had often experienced multiple losses, but especially GPs saw that or perceived older people as more resilient because they had so much exposure to grief. One GP, for example, said, look, their partners, friends, all have passed away. They've become more used to dying, so they're not as affected as severely as the younger patient. Someone else said, look, the oldies just see it as the next step in life. So healthcare staff felt that older people's grief was shorter, less problematic, and often resolved on its own. But as we've seen in the interviews and in the poems, this isn't always the case. So how did healthcare staff pick up signs of grief? Well, interestingly, older people often presented with physical symptoms that didn't appear to be directly related to the grief. So doctors needed to connect the dots. Nurses also mentioned that their nursing care was very intimate, and grief was often brought up as a sideline conversation while they were dressing wounds or giving flu shots. So how was grief managed in general practice? Well, counseling was the first line of treatment, followed by medication. What was rarely discussed, though, in GP consultations were things like support groups or bereavement services or online resources. And that was mainly because staff didn't know what was available. And this brings us to the final topic here, the barriers and enablers of grief support in primary care. Now, communication within the services was really important. So within the clinic team, because the older person might mention that someone had died to the receptionist or to the nurse, but then focus on their physical symptoms when they were speaking to the GP. So team meetings and record keeping were really essential for good team communication. But there were gaps because grief was not really documented in patients' files. Communication between services was also very essential, especially between hospitals, GP clinics, and palliative care services. GPs mentioned that they were sometimes not informed when a patient had died, for example, in the hospital. So how are they then expected to provide support for the family if they don't know that someone has died? Feedback from community nurses was also essential because they would see the older person in their familiar surroundings at home and would be able to pick up signs of grief better. For example, if a person hasn't taken out the garbage for a couple of weeks or the house is in disarray, these are things that the GP would not see when the older person comes for their standard appointment. So communication between services is really important. There are quite a few access issues. For example, the access, availability, and cost of psychologists, mental health nurses, and counselors was a huge problem. But also the acceptability of services, with some people not wanting to see a psychologist because of the stigma and the stereotypes attached. Time was another challenge. Someone said, look, the way most medical systems are constructed, there is no time to be a grieving person. And this is partly because GP consultations are relatively short, but it also takes the older person often a little bit of time to open up and share their grief. One doctor I remember said, look, they leave it until the last minute. You spend 15 minutes building rapport, and then they tell you, they drop the bomb at the end. The final challenge was that there was very limited training on grief. Staff said that it was pretty much learning on the job, and many didn't know how to deal with this. And they also didn't know about things like prolonged or persistent complex grief. Now, these are clinical diagnoses that are given when grief symptoms remain severe and impairing for longer than 6 to 12 months. The ICD now has a prolonged grief disorder category, which is diagnosed when there is a disturbance following the death of a person that's characterized by persistent yearning or longing for that deceased person, persistent preoccupation with the deceased, and these cause a significant impairment in the person's functioning. So, for example, they have then difficulty engaging in social or day-to-day activities. And these symptoms need to persist for longer than 6 months. In contrast, the DSM has added a persistent complex grief disorder as a condition under consideration. Symptoms here include separation distress, so that's very similar to that yearning for that person, reactive distress to the death, difficulty accepting the death, anger, disbelief. There is a social or identity disruption, so people have difficulty trusting others, feel that life is meaningless. And according to the DSM, these symptoms should persist for longer than 12 months. Now, there's a lot of discussion going on around these timeframes with people saying, well, 6 months is too early to diagnose prolonged grief, but others say 12 months is too late to interfere. So this is still ongoing. But there is very limited knowledge regarding these diagnoses among healthcare staff, and also regarding the support services that are freely available. So we've created this little resource sheet here with freely available bereavement and mental health services, such as the Australian Centre for Grief and Bereavement. And I'm very happy to send this to anyone who's interested. And we always encourage people to put this in their waiting rooms or hand out to staff as it is, if it's appropriate. So let me just summarize. Older people are more likely to experience grief, but they're less likely to express their grief. Instead, grief may present itself particularly in physical symptoms and worsened health conditions, which makes it really hard to identify. GPs and nurses play an essential role because they are the first point of contact with the healthcare system. And the entire system depends on them directing people to the appropriate services. But to do that, they obviously need to know what's available. Now, before I hand over to Lidia, I want to leave you with some more videos and poems that capture the perspective of GPs and nurses when it comes to grief.
The symptoms lead you. Old people use symptoms to legitimize their grief, medicalizing, symptomizing. Their knees are aching, their hips are aching, their head's aching. Their blood pressure is up. They don't like doing this, they don't want to take tablets, they're not sleeping well, they don't like food. It doesn't seem like grief. You know it is. You know they're pining. You've got your weather eye open. Their symptoms lead you to find out.
A human being and a nurse. I may say, how's Martha? She passed away. Oh, I get a bit cross, angry, that no one thought to let me know, to put it in the note. I'll often ring and follow up. Sometimes I get in trouble. It's a pain in the bum. We get told it's not my job. I think it is, as a human being and a nurse.
Hidden in the background. You don't see the grief, like somebody arriving off the street for a consultation going, "Hello, doctor, I've come to see you because I'm grieving." That's not their reason to present. Grief is often hidden in the background, amongst consultations, amongst all their normal stuff.
Perfect workforce. Us general nurses, as cheap as chips. Not worth anything, apparently. Give them more funding so that there is time. You've got a workforce who is willing and able. They've got the rapport. Give them skills and they'll do it. They're perfect to help with grief.
So thanks very much, everyone, for listening, and over to you, Lidia.
All righty, let me also quickly share my screen. Are you able to see my slides?
Yes, can see that good.
Okay, all right, great. Now, thank you so much, Kate, and hello, everyone. Now, some of you may know that I'm a health economist by training, and so in the second half of the seminar, I'm going to look at grief from a health economics perspective. And more specifically, as part of this project, we wanted to explore both the health burden of grief in terms of the impact on older adults' health and quality of life, as well as the economic burden associated with grief by exploring health service use. So to address that research question, we developed a survey for online administration and as a paper pen version. And older adults aged 65 years and above residing in Australia were eligible to take the survey if they had experienced the death of a significant person in their lives at least 6 months ago and were able to read and write in English. Now, study participants were recruited via website postings, blogs, social media, and flyers posted on community notice boards. And all these multiple recruitment efforts and really Kate's dedication to this project resulted in 633 valid survey responses. So you can see that the majority of study participants completed the survey online, although about 7% requested a paper pen version. And you can see in this table that most participants completed the survey in May and June last year, with about 23% completing it during the second lockdown in Victoria. Now, while we recruited participants across all states in Australia, we see that the majority resided in Victoria, which needs to be taken into account when interpreting the findings and the impact of COVID-19. So we see here the characteristics of the study population. The majority were female, aged on average 73 years, born in Australia and spoke English at home. Although the sample represents a highly educated group with 37% holding a university degree, 57% reported an annual household income of less than $52,000. Most of study participants were retired, widowed, and lived alone. Now, in the survey, we also collected a number of information about the person who died and the bereavement circumstances. And we can see that the majority of study participants reported the death of their partner, with cancer being the most common cause of death. And approximately half the sample stated that the death was expected and that the person was receiving palliative care. Most participants identified themselves as an informal carer of the deceased person. Now, in the survey, we used the Prolonged Grief Disorder 13 measure, or the PG13, to measure the severity of prolonged grief disorder, which comprises 13 items. And to meet the criteria for prolonged grief disorder, 5 criteria, so A to E, must be met. Now, very surprisingly, we found in our survey data that approximately 21% of study participants met the criteria for prolonged grief disorder, which is higher compared to what was found in a recent meta-analysis of 14 studies, which showed that the pooled prevalence of prolonged grief disorder was 9.8%. Now, the PG13 can also be scored as a continuous scale by summing up the 11 symptom scores that range from 11 to 55, with higher scores indicating greater symptom severity. And you can see that the mean score in our sample was 25.61, which in a previous study was categorized as a moderate risk group that requires additional formal support besides support from family and friends. Now, if we look at the characteristics of those with and without prolonged grief disorder, we can see that those with prolonged grief disorder were more likely to be female, an informal carer, and reporting fewer years since the loss. More individuals with prolonged grief disorder also reported the death of their partner, most often due to cancer, with a slightly smaller proportion saying that the death was expected. Okay, so how does grief now impact older adults' health and quality of life? So if we look at self-reported health, where we ask participants to rate the health on a scale that ranges from excellent to poor, we can see a really nice normal distribution of responses, where the majority said that their general health was good and only 6% said that it was poor. Most of the study participants also reported that their health is about the same now than before the loss, although a large proportion also said that it was somewhat worse now or much worse now. Now, as part of this survey, we also administered the UCLA 3-item loneliness scale that assesses respondents' feelings towards lacking companionship, feeling left out, and feeling isolated from others. So this figure here shows the distribution of responses to the 3 items. where 65% lacked companionship often or some of the time, 66% felt left out, and 75% felt socially isolated often or some of the time. Now, the mean 3-item UCLA loneliness score was 5.87, which indicates high levels of loneliness. Now, unfortunately, we could not find any Australian population norms using the 3-item UCLA loneliness scale, but we found a study in the USA that used longitudinal data from a nationally representative sample of around 2,000 adults aged 50 years and over, that found that the mean loneliness score using the 3-item scale was 3.84 in 2002, 3.80 in 2004, and 4.29 in 2006. And similar estimates were also reported from the 2015 wave of the US National Survey, which was 4.1, and the 2014 wave of the English longitudinal study on aging, which was 4.0. So generally, loneliness scores in our sample were higher than what has been previously reported in older adults in the general population. Quality of life of study participants was assessed using the Equal4D measure developed in Australia, which some of you may know. And it's also a commonly used measure in health economic evaluation. It comprises 12 questions that describe 4 broad areas of quality of life, so independent living, relationships, census, and mental health. And each of the 4 domains include 3 items which are scored on a 1 to 4 scale, where higher scores indicate greater levels of impairment. Now, compared to conventional quality of life measures where a sum score is often derived, the Equal4D scoring is based on preference weights derived from the Australian population, where members of the public were basically asked to rate how good or bad it is living in certain health states, as described by the Equal4D questions, by trading off years of life. And so these so-called utility scores derived from it are anchored on a scale of 0 to 1, where 1 represents full health-related quality of life and 0 is equivalent to being dead. So we see that the mean Equal4D utility score of our study population was 0.58. And if we compare those with the population norms available in Australia, we can see that it is significantly lower than the quality of life of older adults in Australia. And in fact, the same reference here showed also that the mean Equal4D score of 0.58 in our sample was comparable to utility scores previously reported for individuals having depression, which was 0.56, or anxiety, which was 0.57. Now, examining which domains of quality of life are particularly impacted, we can see that greater levels of impairment are visible across the psychosocial domains of quality of life, where the highest impairment, so that's level 4 in amber color, was reported for sleep problems, followed by feelings of loneliness, as well as feeling anxious, worried, or depressed. Now, we further undertook some subgroup analyses to explore the levels of quality of life and loneliness by bereavement characteristics. And we found that quality of life was lower and loneliness levels were higher in individuals meeting the criteria for prolonged grief disorder, those who reported the death of their partner, and those who were full-time carers. We also undertook regression analysis, assessing the predictors of quality of life and loneliness, which are shown in this table. So in the regression model, we included gender, age, whether the person was meeting the criteria for prolonged grief disorder, a variable on who passed away, cause of death, time since bereavement, death expectancy, and whether the person was an informal carer. And similarly to the subgroup analysis, we found that being female, meeting the diagnostic criteria for prolonged grief disorder, and reporting the death of a partner was negatively associated with quality of life and loneliness. Interestingly is that while increase in age reduces quality of life, it was the opposite relationship with loneliness, where an increase in age was associated with slightly lower loneliness scores. So the second part of the survey examined older adults' health service use in order to determine the economic burden associated with grief. So the resource use questionnaire covered the following categories, including health professional visits, emergency department visits, hospital admissions, medication use for mental and physical health, and other services such as aged care services, housing, finance, or legal services. And in all survey questions, we asked respondents to recall their use over the past 6 months. So this table here presents the findings from the health service use question. So we can see that about 88% of study participants visited at least once a GP, with a mean visit of 3.7. Other frequent health professionals included dentists, physiotherapists, and others such as podiatrists, for example. Important to highlight is that despite the fact that 21% of study participants met the criteria for prolonged grief disorder, and the majority reported quality of life impairments, especially in mental health related domains of quality of life, only a small proportion of participants reported visits to mental health professionals such as psychologists, psychiatrists, counselors, and mental health nurses. Interestingly, also are the last two columns in this table, which show the mean visits and the proportion of visits related to grief. Now, this was based on self-report, where we asked participants to indicate how many visits were due to grief. So we can see that while less frequently utilized, most of the visits to mental health professionals, such as psychiatrists, counselors, or social worker, were related to grief. Further, you can see in the table that 16% of study participants also reported visits to the emergency department, and 14% of the participants were hospitalized in the past 6 months, with 8% of those admissions related to grief. If we look at medication use, we can see that 85% reported the use of medication for physical health, while only 26% reported medication use for mental health. Although I think it's hard to make that distinction between physical health and mental health, because you can see, for example, the majority reported use of medication for high blood pressure, which of course could also be due to mental health. Finally, in terms of aged care and other services, only 26% of study participants received an aged care assessment, and of those, the majority were receiving home care services. Only 2 to 7% reported the use of other services such as financial support services, housing support services, etc. Now, what do these numbers mean in terms of dollar figures? So knowing older adults' health service use, as part of this project, we have also attempted to estimate the cost of grief by attaching unit costs to the services used, which were obtained from existing sources such as the Medicare benefit schedule, etc. So if we look at the health professional visits, so this figure shows the mean dollar value per person over 6 months, with the greatest costs observed for GP visits, which was estimated to be $137 per person. Costs for mental health related services, on the other hand, were very small. Now, we did also plot in this figure the costs of visits that were associated with grief, as reported by study participants, although I think it's fair to say that this may not have been always clear to study participants which visit was related to grief and which one was not. So I think the green bars here in this figure are very likely to be underestimated. If we combine the costs of health professional visits with ED visits and hospital admissions, the mean healthcare cost per person was estimated to be $2,563 over a 6-month period, of which again about 307 were reported due to grief, although again this number might be actually underestimated. Now it's also important to mention that this cost figure does not include medication use, aged care services and other services which we are still costing. So the question is now, is 2,563 per person over 6 months a lot or not? Well, we did not have a comparison group in our study, but comparing our findings with the annual treatment cost of, for example, high prevalence mental disorders such as depression, anxiety, and substance use in Australia, which were estimated to be $845 per person, the total cost of our sample are significantly higher, which are also only for 6 months rather than 12 months. So the 845 per person is actually for 12 months. All right, now to conclude and to give us some time for discussion, I think our research has addressed an under-researched area and shows the significant health and economic burden associated with grief in older adults. Our findings have shown that grief and bereavement are negatively associated with older adults' health and quality of life, especially across psychosocial aspects of quality of life. We also saw concerning levels of loneliness in our sample, particularly in those meeting the criteria for prolonged grief disorder and informal carers. The resource use data has clearly shown that mental health services are less utilized by this cohort despite reporting prolonged grief disorder and other mental health problems. Now, overall, I think this highlights the importance of GPs as the gatekeepers to the healthcare system and points to the urgent need to targeted interventions to enable more timely support and encourage help seeking among bereaved older adults. And with that in mind, thank you so much for your attention, and I will open up now for discussion. Thank you.
All right, thank you so much, Lidia and Katrin, for that presentation. So we now have some time for Q&A. Please submit any questions that you have in the chat, or if you'd like to ask your question in person, you can turn on your camera and microphone now, and we'll be able to call on you in turn. So while we wait for people to construct some questions for the two of you, I've got a couple. My first one was your finding about the benefits of voicing loss. Seems like it would have possibly quite a correlation with people willing to participate in a research project talking about their loss. Did you find that the participants involved had any direct benefits from their participation in the project?
It's a good question, Jess. I feel they did. So it's hard to conclude because we didn't do a follow-up with the participants individually, but through the process of creating the poetry, and then we send them the poems to allow them to check their poetry to make sure that they're happy with this. We often received a fair bit of feedback, and they really loved being given a voice. And especially the poetry component of the study, I felt gave them the opportunity to share their story and feel heard and feel like their story matters and it might actually benefit someone else because they might feel less alone and isolated in their experience and feel encouraged to go and talk to someone. So I feel there is, from the feedback that we got from the participants, there was some reports about that this really helped them to feel less lonely in their grief.
Fantastic, thank you. We have a question coming through from Bryony. She says, thanks Katrin and Lidia, excellent presentations. Did either of you explore the barriers to access to health or mental health services that could support them in their grief?
So we looked in the interviews, we looked at the barriers to accessing primary care support or support in general. And we found that there were, as I mentioned earlier, so things like availability of mental health support, concerns about stigma, also the cost. A lot of people said they were hesitant because it costs so much money, and things relating to these sort of general concerns around mental health. They were brought up quite frequently. Travel distance sometimes was mentioned. So these were things that were addressed in regard to mental health specifically. I guess, one thing that I noticed in the interviews with the GPs as well and the older people, that they were, GPs wanted to refer people on to mental health support, but then older people might not accept this. So it's a tricky balance, and I'm not sure if that answered your question.
Yeah, thanks, Katrin. I guess what prompted it was just thinking, when you're doing the health service utilisation work, you can only look at what they've used rather than what they might need and what's available. And I was just curious to know, because there's not a lot available for older people experiencing grief, in my experience. So, I was just curious as to whether that came up as an issue. Thanks.
Can I just add something to it? So I forgot, we only had so much time, but as part of the survey, we actually also explored unmet needs. So we did explicitly ask participants, and I just have the question here in front of me, whether they needed to see a health professional regarding grief, but decided not to. And it's actually quite interesting what participants were reporting, with the majority saying, so in 38%, that they felt it would be inadequate, followed by cost as a reason, or the waiting time too long or not available. And of course, because the survey was completed due to the lockdown time, so COVID-19 was also sometimes highlighted as a reason why people decided not to seek help from a health professional. But I think that 38% said that they felt it would be inadequate. I think that really reflects to what Kat was reporting from the qualitative interviews.
Yeah, and can I just add to this? I guess it also highlights, like Bryony was alluding to, it highlights the need for tailored support services, because older people are grouped into this homogeneous group of 18 plus. Just general adults, but they have very specific needs because of their frequent exposure to grief and bereavement, because of potentially pre-existing medical conditions, because of their life experience. So there are very few very tailored services that are targeted towards older people, and that's a clear gap here.
Interesting. Our next question is from Joan. She says, great work. Do you have any suggestions for overcoming the stigma attached to seeking professional help?
Lidia, do you have any thoughts on that?
Well, I think one thing that we kept reiterating in our presentations is the importance of the GP, who is kind of the gatekeeper and who should refer people to appropriate services. But I think something that also came from the interviews that Katrin undertook with GPs, many GPs are not even aware themselves of which services are available. So how can they direct their patients to other services? So I think there is kind of we probably need to intervene in terms of educating health professionals about grief support services. I don't know, Kath, if you...
I totally agree. And I guess, the GP as a point of contact is such a great, valuable resource to destigmatize this. If they make them feel like this is okay, this can happen, there is support available, then, this puts the patient at ease right away. And I guess part of the reason why we were creating these poetry videos was also to address this stigma, so that we can share this with a wider community, so that older people can watch these videos and see other people are going through this too, and they still struggle, and it's okay to ask for help.
Thank you for that. Sue, do you have a question for Katrin and Lidia?
I do. Thanks, Jess. One of the most powerful poetries, but also the relating to the cost effectiveness for me was the poem that Lorraine read as a nurse, looking at we just need to know what to do because we're the people that are in contact. We just need a few more skills. And I'm wondering also, as a health professional, you see that people visit, you've mentioned GPs, but physiotherapists and podiatrists in particular are seeing people, and they are services that do offer a lot for older people. I'm just wondering if you could comment about how we should give those people, as Lorraine's poem indicated, the skills and the resources to be able to act. And it may not be that they refer to another service, because we know of the waiting list problems, but is there something that those frequent seen professionals could do?
I think that's a really good question, Sue, and I think it alludes to what Lidia said earlier, this need for training. So I think grief support needs to be part of healthcare professional training, no matter what you do. If you have if you are in contact with patients, this can come up in multiple settings, like you said. So it needs to be integrated in trainings more frequently. And I guess one other thing that Lorraine's poem alluded to, or that nursing poem alluded to, was the roles. She felt that that it was almost punished by the system if she did follow-up phone calls with the patient to check if they're okay, because this is not part of your role. And I think this is a thought that needs to be eradicated, and that needs to change, as we're supporting older people and through this process.
Excellent. Well, thank you, Sue. We've got perhaps our final question from Tanya. She asks, where can we gain access to this study, please? Would you like to elaborate on any plans for publication?
Yeah, it's a really good question. So we're now writing up these findings. So this is all very new. We just completed the study a couple months ago, writing up the findings for publication. We're planning to develop hopefully an online exhibition with the poetry to share this more widely. We're currently applying for funding for this. So if anyone knows anyone who's interested in funding projects like that, please do let me know. We're also trying to distribute, especially the poems, more widely, for example, through La Mama. They have a Poetica series which will be joining next year. Other than that, I would say watch this space, and we'll let you know once things are being published and are accessible to the wider public.
Fantastic. Well, if we don't have any more questions for Katrin and Lidia, thank you so much for joining us today. Everyone, please join me in thanking them with your clap reaction.
Thank you for having us.
Thanks, guys.
So next week, we're going to be hearing from Dr. Andrew Gilbert, who'll be presenting Emotional Care by Culturally and Linguistically Diverse Carers of People Living with Dementia. So join us next Tuesday at midday, and thank you all for attending our Seminars in Aging program.